Welcome to this video podcast of the Wits Journal of Clinical Medicine. I'm Pravin Manga. I'm the editor of the journal. So for today's video podcast, I'm delighted to have Derick Raal. Derick is a colleague of mine and he's currently the academic head of the Division of Endocrinology at Wits, and he's an internationally recognized expert on lipidology. His research interests largely in the field of familial hypercholesterolemia, a condition not uncommon in certain sectors of our population, and he has contributed hugely in the management of these patients here and internationally. So welcome, Derick. For today, I'd like to discuss on the topic of novel new therapies for hypercholesterolemia. Over the past decade, we've seen a huge leap in the number of these new novel agents that have become available and will be available soon in South Africa. But before we discuss the new agents, briefly about this kind of basis of therapy for hypercholesterolemia still remains statins. And maybe you can give your experience on the effect of statins, their side effect profile, and probably the combination of statins plus Ezetimibe.
Sure, thanks for the invitation, Pravin. It's been a remarkable sort of period the last 30 years. 30 years ago, we had very little to treat hypercholesterolemia. And then the first drug that really worked were the statins, which was in the early 90s. This is about 30 years ago. And that drug really revolutionized the treatment of hypercholesterolemia. Now it's one of the biggest drugs used in the world. It's more popular than aspirin. But as you mentioned, some people still worry about the side effects, and there's this Dr. Google that everyone goes to, and they think the statins are responsible for dementia, impotence, all these sort of side effects. But in theory, they're remarkably safe drugs. They're actually safer than aspirin. The only real side effect that occurs occasionally with the statins is muscle problems like myalgia or weakness in the muscles. But many people get aches and pains and they put it down to the statin. So more recently they've done N=1 study. So a very interesting study was the Samson study, where people were given 12 bottles. 4 were empty, 4 contained a statin and 4 contained a placebo. So it was a month of each treatment. And every day they just had to record their side effects. And they weren't interested in the empty bottles because during that time patients all had no side effects. But they wanted to compare when patients were on statins versus placebo, and there was actually no difference in side effects. So many of the so-called perceived side effects of statins are probably not due to the drug. So they are remarkable drugs, and they still remain the background therapy for our patients with hypercholesterolemia. However, with the new guidelines, the targets are going lower and lower. So top doses of our most potent statins would reduce LDL cholesterol, which is the real bad boy, by about 50 to 60%. So particularly for patients with familial or inherited hypercholesterolemia, a 50% reduction would not be sufficient. So that's when we have to think about newer therapies. And what is underutilized is the drug called Ezetimibe, which is a cholesterol absorption inhibitor. It just stops you absorbing cholesterol from the gut. And it reduces on average your cholesterol by about 20%. And very much like we treat hypertension, in the old days we used to use just a single agent. But now for the treatment of hypertension, we often start with combination therapy, like an ACE inhibitor plus a diuretic. And the European guidelines are now recommending in high-risk patients, so anybody who's had a heart attack or a stroke, patients with familial hypercholesterolemia, we should consider combination therapy right up front, because with the two together, statin plus Ezetimibe, we can get a 70% reduction in LDL cholesterol, which for many patients would be sufficient. It's just underutilized treatment, and definitely the first time we see our patients up front, if you start them on good therapy, that's the time to introduce the therapy, and that's would be now recommended as standard first-line therapy for patients with severe hypercholesterolemia.
And for our viewers again, Ezetimibe is essentially now a generic version available, so it's not as expensive as before.
Exactly right. So in fact, statins are generic, so they're cheap. They're cheaper than a cup of coffee, even the top doses of statins. And Ezetimibe, now that it's become available as a generic, is also much cheaper. What we will have within the next probably 6 months or so is actually generic combinations. So in the same tablet, you'll have a statin plus Ezetimibe as a single tablet, which will also improve compliance for patients. Because that's the sort of most important. The important thing about these treatments is you have to take your tablets every day. So on that basis, we can perhaps talk about newer therapies that are coming.
So yeah, talking about that, so let's go to the one newer therapy that is some drugs are available, the PCSK9 inhibitors. So firstly, for our viewers, what are they and how beneficial they fit into our treatment paradigms?
Yeah. So PCSK9 is a very interesting molecule. It's produced by the liver, and the reason it was discovered is they saw patients that looked like they had familial hypercholesterolemia, but they had nothing wrong with their LDL receptor, which is the big problem in familial hypercholesterolemia. What PCSK9 does is it attaches to the LDL receptor and basically destroys the LDL receptors, so it keeps your LDL receptors on the surface nice and fresh. You produce new ones all the time, so it mainly acts in the liver. So if you knock out PCSK9, that means all the LDL receptors are returned to the cell surface, the old ones and the new ones, and inhibiting PCSK9 can reduce LDL cholesterol a further 60%. So on top of statin plus Ezetimibe, you get another 60% reduction. So with this therapy, you can reduce LDL cholesterol levels in most patients to extremely low levels. So the first way of knocking out PCSK9 was with a monoclonal antibody. Now, unfortunately, to develop monoclonal antibodies, it's expensive. So these therapies which are now available, there are 2 monoclonal antibodies directed against PCSK9. They're given as a sort of fortnightly injection, but they are very expensive. Currently in South Africa, they're about 6,000 Rand per month. Yeah. So expensive, but remarkably effective, and a very good additional therapy. The problem is just the funding, and for most patients, medical funders are not covering the costs of these agents. It's difficult because, in another field like rheumatoid arthritis, we use monoclonal antibodies for bad arthritis, and those are being funded by the medical funders. So cholesterol, the problem with high cholesterol, it's an asymptomatic condition. So patients feel well, they look well, they don't complain as much as the patients with bad joints. So we're struggling to get these drugs funded. But for the deserving patients, particularly the more severe patients with familial hypercholesterolemia, somebody who's had a myocardial infarction, the current recommendations internationally is that we should consider PCSK9 therapy at the time of a myocardial infarction because you get a marked reduction in LDL cholesterol and stabilization of the plaques.
So I agree with you, Derek. It's a funding issue, so it's not an indication issue. And you can play around with the dosing schedules. Instead of giving twice a day, you can sometimes give it twice a month. You can give it once a month. And that way reduce the cost, or even sometimes once every 2 months. So there are multiple ways you can overcome the cost issues. But cost is an issue.
Sure. No, and when we first started with statins, they were expensive, and now they're generic. So if cost wasn't an issue, we'd be using these drugs also much, much more frequently. The big advantage of the PCSK9 inhibitors is that unlike statins, which work mainly in the liver but also work in the muscle cells, that's why you can occasionally, very uncommonly, get the muscle side effects. There's no muscle side effects with the PCSK9 inhibitors. So for that group of patients who really believe statins are causing their side effects, this is another option. But the funders are not going to give you a PCSK9 inhibitor because your muscles are a little bit sore, you get joint pains or whatever. Yeah.
All right, so they are new therapies that are now currently available in South Africa. What about the new agent inclisiran, which appears on the horizon and has some substantial advantages?
Sure. So we were very lucky to be involved in studies with inclisiran. So the way the monoclonal antibodies work is they're mopping up PCSK9 produced by the liver. But it makes more sense to sort of mop up by having to give an injection every fortnight. Why not turn off the tap? So inclisiran is a drug called a small interfering RNA, and it turns off the production of PCSK9 by the liver. So instead of having to be given once every 2 weeks, you can give inclisiran once every 6 months, so twice a year. And this therapy, it's like a vaccine for cholesterol, will halve your cholesterol level with a twice yearly injection. So for compliance, it's wonderful. It's like having a vaccine against, coronavirus or whatever. It's exactly the same. You're guaranteed. So you know that even if the patient doesn't take their statin and the other therapies, you're going to halve their LDL cholesterol level with this drug called inclisiran. It's become available in Europe now. It's just been launched in the United States, and it's going to revolutionize the future therapy of hypercholesterolemia because you've got guaranteed compliance with a twice yearly injection. Once again, it's a novel therapy, it's new, and it's probably going to be costly. We don't know what it's going to cost in South Africa. In Europe and the United States, even with a twice yearly injection, it's a similar price to the monoclonals. But I would think in the future, and particularly in our environment in South Africa, we need to have a substantial lower cost for this therapy. And then it'll be used widely because it's a very effective therapy with very little side effects other than having to give a jab twice a year.
You think the Department of Health might get into that space as in the UK, where the National Health Service have bought into therapy of inclisiran for their population?
Exactly right. I mean, if you think about it, the cost of managing particularly people with established cardiovascular disease, in other words, you've had a heart attack and looking down the line, stents, cardiologists, bypass surgery, etc. So what they've done in Europe is anybody who's had a cardiovascular event, a heart attack or whatever, they are getting inclisiran. And so the long-term cost saving is going to be huge. There's an upfront payment, but in terms of health of the population, reducing future events, that's definitely the way to go. So we need to look at these sort of therapies, and I think particularly if you're going to be giving it to a sizable percentage of the population, then there may be an advantage for the pharmaceutical industry to reduce the price so that it can be given to deserving patients. Yeah, we were very fortunate. We did one of the first studies in our patients with familial hypercholesterolemia, which really showed how effective this therapy is.
So that's a remarkable drug. So those are two clear PCSK9 inhibitors in different formats. What about the other new novel therapies such as bempedoic acid? Is that available here?
So not available here. It also works in the same pathway as statins. So it also works on cholesterol production within the cell. It's a milder, it's not nearly as potent as the statins, but the advantage, it's administered as a prodrug. So in other words, it will not get into the muscles. It has to be activated in the liver. So unlike the statins, the advantage seems to be no muscle side effects. The problem is its reduction in LDL cholesterol is modest. It's about 20%. So it's in the same ballpark as ezetimibe. So where I think it will be used is for patients with statin intolerance, and it's a new drug, and they haven't read about it on Dr. Google yet, so maybe a combination of bempedoic acid and ezetimibe. But even that combination, you're not going to get the LDL cholesterol reductions that we see with the newer potent agents. And when we really want to get the levels down to very low levels in patients with established disease, I don't think it's going to have a major role.
Thanks, Derick. And so any kind of insights into some of the new potential therapies that are being investigated? You're at the forefront of research into this area, both locally and internationally. So give our viewers some taste of what may be coming.
Yeah, so another very interesting group of drugs are called the ANGPTL3 inhibitors. It's a drug called evinacumab. Now, ANGPTL3 is another protein produced by the liver, and it inhibits what we call lipoprotein lipase and endothelial lipase. So which basically reduce remnant particles, so triglyceride and cholesterol-rich particles. So if you knock out ANGPTL3, you clear these remnants remarkably quickly. So this is potentially a drug, and it can be used for both severe hypercholesterolemia. We've just recently done a study in our homozygote patients. And now our homozygotes, I never thought it would happen. I mean, 30 years ago, we had no treatment for these patients, but now they're on a combination of statin, Ezetimibe, a PCSK9 inhibitor, and this drug called Ezetimibe, and we're getting their cholesterols to below 5. I never thought it would happen in my lifetime. But once again, it's expensive therapy. It's a monoclonal antibody, but potentially we also there are now drugs that are going to work as small interferon RNA against ANGPTL3. So it'll be have to given much less frequently.
Turning off the tap is good.
Turning off the tap. And so I'm hoping in the future, just with a couple injections in inclisiran plus a small interfering drug against ANGPTL3, we're going to be able to even treat the most severe cases of homozygous familial hypercholesterolemia. So the big new field is we've got very good drugs for reducing LDL cholesterol, but the new field is like remnants where ANGPTL3 inhibition may come in. And then another interesting area is lipoprotein little a, which is a new novel particle which also seems to be atherogenic. And we're now developing drugs that can inhibit LP little a. So lots has happened in the field of lipidology over the last 20 to 30 years. And I think we're going to have very new therapies. And whether we're going to eradicate atherosclerosis, I still think is a far way off. I remember Goldstein and Brown, who discovered the LDL receptor when statins were discovered, which was at the end of the last century. They said we're going to cure atherosclerosis. The problem is patient compliance. And what we tend to do is we wait until we've had our heart attack and then we start taking therapy. But particularly patients with familial hypercholesterolemia, we're now recommending starting treatment at the age of 8. So it's like brushing your teeth. You brush your teeth not to need fillings later. For patients, we see the parent, the index, the father who comes in with his heart attack, we test the children and we start treating them from a very young age. And actually, they're very compliant. They don't want to have the heart attack like their dad did. So compliance, if you get the children started at an early age, will prevent the disease later on.
Yeah, so the general tendency is to start statin therapy much earlier than what we used to saying you only start statin therapies in your 50s, etc.
Sure.
But any patient with significant familial history of premature MI, etc., that you should consider, especially if their cholesterol levels are high, to start very early.
Very early. And what they've shown that with the Dutch data, and so in the Netherlands where they did universal screening for familial hypercholesterolemia, they've now shown that having started the children at a young age, around about the age of 10, they're now outliving their parents with the condition, and their mortality is the same as the healthy background population. So if you start early and prevent atherosclerosis from ever occurring or developing, you can live a healthy, normal life. So that's one of the most important messages, is when you see patients coming in with premature coronary artery disease or a heart attack, you've got to take a family history. You have to test the children, and the best thing you can do for that family is test the children and start treating them early. In South Africa, we have one of the highest prevalences of FH in the world. So around the world, it's about 1 in every 300 people. But in South Africa, in our Jewish, Afrikaner, and our Indian populations, it's closer to 1 in 80. So we have 200,000 people minimum with familial hypercholesterolemia in South Africa. The vast majority are undiagnosed and untreated because they're asymptomatic. They feel totally well.
So Derick, I think our time's up. Thank you for those wonderful insights into the novel therapies for hypercholesterolemia. It's a field that is continuing to expand and advance. And thank you once again for enlightening us with all your research and interest in this field. Thank you.
An absolute pleasure. Thanks again.